The male reproductive system operates as a precisely calibrated neuroendocrine circuit. To understand how it fails, we need to map the hypothalamic pituitary testicular axis, tracking the signal from the central pacemakers in the brain down to the peripheral target tissues. By isolating exact genetic mutations and enzymatic lesions at specific nodes on this map, we can deduce the entire spectrum of male reproductive pathology. Mastering board-level endocrinology requires tracing these biochemical pathways. Diagnosing complex disorders of sexual development relies on deductive logic, not rote memorization. The circuit begins in the arcuate nucleus with the central pacemaker, the KNDY neurons. These cells feed rhythmic signals into the GNARH neurons. This pulsatility is strictly regulated by the paternally expressed MKRN3 gene, which functions as an upstream inhibitory brake on GNARH release. When a patient inherits a loss-of-function mutation in MKRN3 from their father, this brake breaks. The result is an unchecked, premature surge of GnRH signals, triggering central precocious puberty. Conversely, mutations in the accelerator genes, like KIS1 or TAC3, prevent pubertal onset entirely. This results in normosmic idiopathic hypogonadotropic hypogonadotropism, a failure of the central drive with an otherwise intact sense of smell. This isolates it from Kalman syndrome, where an ANOS1 mutation prevents the physical migration of GnRH neurons during embryonic development, directly linking the resulting hypogonadotropism with anosmia. A single genetic hit at the hypothalamic node dictates whether puberty occurs years early, never arrives, or is accompanied by the inability to smell. Moving one layer down, the pulsatile GnRH signal reaches the pituitary gland. Here, the rhythm dictates the release of two distinct hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. The pulsatile nature of this signal is an absolute requirement. Continuous exposure to exogenous GnRH paradoxically shuts the entire axis down. Once released, LH targets the Leydig cells in the testicle, inducing the star protein to initiate testosterone synthesis. Meanwhile, FSH targets the Sertoli cells. These cells support spermatogenesis and produce inhibin B, which travels back up to selectively suppress pituitary FSH. This anatomical split allows us to map specific defects. ACFC microdeletions on the Y chromosome exclusively impair the seminiferous tubule compartment, directly dictating the prognosis for surgical sperm retrieval. Because of this dual pathway, a selective elevation of FSH, while LH remains normal, localizes the lesion entirely to the seminiferous tubules, indicating that Leydig cell function is fully preserved. Inside the testicle, the star protein dictates the precise rate of testosterone synthesis by actively transporting cholesterol molecules across the inner mitochondrial membrane. Testosterone itself is largely a prohormone. To drive the full spectrum of male physiology, it faces a critical biochemical bifurcation. In the first pathway, the enzyme SRD5A2 converts testosterone into the highly potent dihydrotestosterone, or DHT, directing the differentiation of the urogenital sinus and prostate. A deficiency in SRD5A2 produces a distinct 46XY disorder of sex development. An infant is born with female-appearing external genitalia, but virilizes at puberty when the type 1 variant of the enzyme becomes active in peripheral tissues. In the second pathway, the CYP19 aromatase enzyme converts testosterone into estradiol, managing epiphyseal closure in the bones and regulating skeletal density. Mutations here produce severe extremes. A CYP19 deficiency leaves patients with unfused epiphyses and unusually tall stature, while an excess of aromatase activity drives extreme estradiol production, causing true gynecomastia. These peripheral conversion enzymes act as the true arbiters of androgen action, determining whether the hormone's final effect manifests in the structural development of the skeleton or the anatomy of the genitalia. The final layer of the axis lies in the receptors that intercept and translate these hormonal signals. In familial male-limited precocious puberty, or testotoxicosis, an activating mutation forces the LH receptor to drive constitutive CAMP signaling. The Leydig cells synthesize massive amounts of testosterone, entirely independent of pituitary LH. Compare that to complete androgen insensitivity syndrome, or CAIS, an inactivating mutation of the androgen receptor. Here, the feedback loop is entirely severed. The pituitary pumps out high levels of LH, driving immense testosterone production, but the broking receptor ignores the signal completely. Because the androgen receptor is completely silent, that massive pool of unused testosterone is forcefully aromatized into a severe excess of estradiol. This results in a 46XY individual presenting with female external genitalia and primary amenorrhea. A serum hormone level carries no physiological weight without an intact, correctly functioning receptor to translate it. With the HPT circuitry mapped, we can apply it directly to clinical diagnostic algorithms when evaluating hypogonadism. The quantitative relationship between total testosterone, confirmed precisely by liquid chromatography tandem mass spectrometry, and the gonadotropins LH and FSH tells us exactly where the circuit is failing. High gonadotropins isolate the defect to primary testicular failure, while low or normal levels point upward to a secondary central defect. This brings us to the exogenous paradox, frequently seen in cases of anabolic androgenic steroid abuse. Flooding the system with exogenous synthetic androgens triggers massive negative feedback. The hypothalamus and pituitary flatline their release of LH and FSH, driving intratesticular testosterone to near zero, resulting in severe withdrawal hypogonadism and deep infertility when the steroids are stopped. This chart shows the results of the Landmark Traverse trial, plotting the cardiovascular outcomes of testosterone replacement therapy in hypogonadal men. The data resolved a long-standing question. TRT does not increase the risk of major adverse cardiovascular events. However, it does carry distinct elevated risks for venous thromboembolism and atrial fibrillation, requiring careful patient screening. Clinical mastery of male reproductive endocrinology is not achieved by memorizing disconnected lists of symptoms. It is achieved by deeply understanding the exact biochemical nodes that govern the HPT feedback loop and deducing exactly where the signal breaks.